Welcome to Davis, California. This is the hometown of UC Davis, located 15 miles west of the state capital, Sacramento. We gather at the Richard Brunel Performance Hall today for a colon cancer prevention seminar, bridging medicine, and music. I am Dr. Ronald Hsu, Governor for Northern California of the American College of Gastroenterology and Clinical Professor of Medicine at UC Davis School of Medicine. I am honored to direct this program with music directors Angelo Moreno and Michael Sand in collaboration with the Davis Senior High School Baroque Ensemble and the American College of Gastroenterology as a promotional partner. Thank you to ACG President Dr. Shah and the ACG physician experts for embracing this program. In addition, this community event would not have been successful without the help of the organizing committee, ACG IT and promotional support, industry and private practice sponsors, and our industry partners. I also thank Davis Senior High School's stage management team and the Davis Media Access technical support team and eBuyer. I am indebted to our music directors who have curated an outstanding program and our young musicians who have spent countless hours rehearsing for this event. Our program aims to raise awareness and prevent the second most common cause of cancer death in the United States. Bridging Baroque music from the 17th century to modern medicine of the 21st century is a challenging and exciting endeavor. At the end of this program, I hope both the message of colon cancer prevention and the beautiful melodies of Baroque music resonate with us. Together, we will take action to prevent this deadly disease and enjoy Baroque music to maintain our state of well-being. The program has two parts, the roundtable discussions and the music performance. We have a great lineup of 16 physician experts to update us on the advances and address why and how to prevent colon cancer. After a short intermission, the Davis Senior High School Baroque Ensemble will perform the concert. I am happy to introduce now the President of the American College of Gastroenterology, Dr. Shah.
The current president of the American College of Gastroenterology. He is a clinical professor of medicine at Brown University, the chief of gastroenterology at the Miriam Hospital, and a partner at Gastroenterology Associates, Inc. in Providence, Rhode Island.
I'd like to start by thanking all of you for attending and welcoming you. I want to thank our organizers, Dr. Ronald Hsu, who's the governor for Northern California for the American College of Gastroenterology, and his whole team that helped put this together, including Dr. Joseph Leung, who's a master of our college, Dr. Andrew Yen, who's also a fellow of our college, Anne Louise Oliphant, who's vice president of communications for the American College of Gastroenterology, Angelo Moreno, who's director of orchestras at Davis Senior High School, and Michael Sand, music director for the UC Davis Baroque Ensemble. Here are the real stars of the show, the Davis Senior High School Baroque Ensemble themselves. I know they've been working very hard to put this together and practicing nonstop, so I can't wait to hear them play. Well, why is this so important? We know that colon cancer is preventable, and we want to get at least 80% of all eligible patients screened for colon cancer. There are many reasons why this may not happen. It could be lack of awareness, lack of knowledge about the importance of colon cancer screening, lack of trust in the medical system, lack of availability and access to screening services, and then the COVID-19 pandemic has added additional challenges for access. Again, why is this so important? It's because this common cancer is so preventable. In 2021, there were over 149,000 Americans diagnosed with colon cancer, and that included over 15,000 residents of California. Over 52,000 Americans died of colon cancer, and that included over 5,000 Californians. Now, again, we want to get to at least 80% in every single community. And colonoscopy is a powerful tool and a good option, but the best screening test is the one that gets done. How close are we? This is data from the American Cancer Society, and back in 2018, we can see that several states in New England were getting close to that goal, but California lagged behind. How about in 2021? This is taken from the America Health Rankings, and you can see that overall in the U.S., 74% of people were screened, and Maine and Massachusetts led the way with 81%. Rhode Island was not far behind at 80%, but California lagged at 62.4%, making it 50th in the state. So California needs to really catch up. This is really so important with the COVID-19 pandemic because that's reduced access to colon cancer screening. When the pandemic first hit, there was a 90% reduction in access to colonoscopies, and this is going to result in a lot more patients, unfortunately, dying from colon cancer because of the lack of screening. We need to identify inequities. The pandemic has basically magnified inequities that were already there. We need to track as we recover and get patients back into appropriate screening programs. And we need to anticipate the challenges in doing so. We know that telehealth doesn't work for everyone, especially patients who don't have access to internet. And again, our focus is to prevent the cancers and prevent death from these cancers. We know that disparities in colon cancer existed before the pandemic, and both in terms of incidence rates of colon cancer as well as death rates. And it's so important that we address these as we try to battle colon cancer. So how do we do it? Well, I love the analogy of bridges. Bridges connect two previously separate isolated areas to each other. And I love that music is being used as a bridge here. Music can help with stress and burnout, but it's going to increase awareness of colon cancer and the importance of screening in the entire community. So it's not just going to be you, but it's going to be your families, your friends, and the whole community. And this is modeling for others to make their own bridges to increase awareness for the importance of colon cancer screening. I'll have to share that my favorite musician is Sting, and coincidentally, he's come out with an album, The Bridge. So I'll end with a little quiz. What's the major risk factor for colon cancer? A, not having screening. B, not having screening. C, not having screening. And finally, D, all above. Well, you know the answer. And for extra credit, 45 is the new 50. That's right. Colon cancer screening should begin at age 45 now. So what do superheroes say? And these are my kids when they were 3 years old. Now they're 16. Holy prevention, Batman. We have to remind everyone to go for colon cancer screening. It's part of being a superhero for our community. Thank you all for being superheroes for your community, and I look forward to the program.
Dr. David Greenwald is immediate past president of the American College of Gastroenterology and is professor of medicine at the Icahn School of Medicine at Mount Sinai in New York City.
So let's talk some facts and figures about colorectal cancer and then a few words on strategies to prevent colorectal cancer. Colorectal cancer, unfortunately, is way too common. In fact, it's the second most commonly diagnosed cancer in the United States and the second leading cause of cancer death in the United States. If you look at statistics, 150,000 new cases per year, almost 50,000 deaths per year. This actually accounts for 9% of all cancer deaths in the United States, and obviously very expensive to our healthcare system as well. This is not only a problem for the United States, colorectal cancer is a problem worldwide. On the left, you see a map that shows the world. Any place that you see in red are high areas of colorectal cancer. So you see the United States, Australia, and much of Europe. The areas that are in green are particularly low areas, and you see most of Africa and India and a couple other countries as well. The graph on the right shows basically the same thing but from about 10 years later. So this is data from 2012, and it goes from the more developed regions having colorectal cancer, and as you go to the bottom of the graph, it's the less developed regions having colorectal cancer. And again, you see the same thing, high prevalence of colorectal cancer in Australia, Europe, and North America. This depicts colorectal cancer and screening activity as compared to other things that we screen for in medicine that are very, very important, things that are very widely accepted, including pap smears, which is on the dotted bars on the top. The dotted line just below the pap smear line is for mammograms. So those are the rates of screening in the United States for pap smears and mammograms. And you see they've been pretty constant over several decades. You see the rate of screening for colorectal cancer steadily increasing over a 20-year period from 2000 to 2020, representing great progress that we've made. Colorectal cancer screening is also not the same all around the United States. So this is a map of the United States, and you see depicted here different rates of colorectal cancer screening in different states. In this case, it's good to be blue, and you see high rates of screening, over 70% along the East Coast and along the West Coast and several other states. Any areas that are in orange or red have relatively low rates of screening, and you see those mostly in the Deep South and far north. And this is the way that we look at colorectal cancer screening most commonly in terms of the rate of screening. It's using something called the Behavioral Risk Factor Surveillance System, or BRFSS. And you see a steady rise in colorectal cancer screening in the United States between 2000 and 2016. This trend has continued to 2022, up to almost 70% in this country. And this is the bottom line. You can see over the past 30 years, a decreasing incidence of colorectal cancer in both men and women that you see on the top graph, and you see a decrease in the death rate or mortality for both men and women in colorectal cancer. This is the bottom line. This is really, really important. So let's just turn to a couple of strategies in prevention. Importantly, colorectal cancer is mostly preventable. I will end with that. But in terms of strategies, we want people to have a menu of options. We want choices for people to have because we want as many people engaged in this as we can. The concept of shared decision-making means that each patient and each clinician works together to find the choice in colorectal cancer prevention that is best for them. We have excellent evidence that screening works. We know that screening is underutilized. I've shown you that 2/3 of people are up to date with colorectal cancer screening now, but that means 1/3 aren't up to date. And we know that screening is appropriate for average risk individuals and is recommended now in multiple guidelines for average risk individuals between ages 45 and 75. These are the choices that are available to people. They include direct visualization tests, which include colonoscopy, sigmoidoscopy, and CT colonography. And those are indicated for average risk people at intervals of 10 years, 5 years, and 5 years. And stool-based testing, which includes FOBT, or fecal occult blood testing, FIT, which is fecal immunochemical testing, or stool DNA combination with FIT. And those are indicated every year or every 1 to 3 years. And importantly, if one chooses a stool-based test and it is positive, that person needs a follow-up colonoscopy within 3 months to complete the screening process. The National Colorectal Cancer Roundtable established a goal, which you see depicted on the left, of 80% screening in the United States by 2018. We are still continuing to work toward that goal. But as you can see on the right, the new campaign is called 80% in every community. And that's because a community can be anywhere that you are, a geographic place, the people you work with, the people you know, and we can hit 80% in every one of those communities. I leave you with this thought. Colorectal cancer is largely preventable. When it is not preventable and it is caught early, it is treatable. And therefore, colorectal cancer is beatable. I finish with this thought. The best screening test is the one that gets done. We want everybody to be screened with whatever test works best for them. Thanks very much.
Dr. Mark Pochapin is a past ACG president. He is the Schultz Leeds Professor of Gastroenterology and Professor of Medicine, and the Director of the Division of Gastroenterology and Hepatology, as well as Vice Chair of Clinical Affairs in the Department of Medicine at NYU Langone Health in New York City.
When we look at colorectal cancer statistics from 2020, we see 3 patterns. First, and very disturbing, is an increasing incidence and mortality for young adults less than age 49. Now, if you look at the y-axis, the actual number is not as high as for older adults, but the trend is increasing, and truthfully, we don't know why. More research needs to be done on this. We see a slight leveling off of the improvement we had seen previously for 50 to 64-year-olds. We had a decreasing incidence, and now it's beginning to level off a little bit. Although this has gotten better and is beginning to decrease a little bit, we think, over the past few recent years. And finally, a very significant declining incidence of mortality for adults greater than age 65 years, primarily due to colorectal cancer screening. And this is a real public health success story. The first way to do better is just focusing on quality. So using a quality repository like GIQuIC actually makes us better. Looking at ADR, withdrawal time, techniques, using a report card that reports these type of metrics, and making sure preps are done appropriately with a split prep. Focusing on quality actually improves quality, and people who use GIQuIC as a repository have been shown to have higher ADRs year after year. When we look at colonoscopy technology and the improvements, we see top to bottom in attachments, the cap, the endocuff, the endo rings in scope design, a balloon that stays permanently affixed to a colonoscope, wider angle of view, tighter retroflex, and finally, artificial intelligence. On meta-analysis, pulling back the folds mechanically may be better and have a slight advantage to optical means of improving colonoscopy. And in this meta-analysis with AI and polyp detection, there was a 44% relative increase in ADR without any effect on the efficiency of colonoscopy. New non-invasive colorectal cancer tests are very exciting and may be able to detect colon cancer in the blood, the stool, and the breath. These include molecular markers that are best for staging, response to treatment, assessment for metastatic disease, DNA changes such as mutation and methylation markers, and particularly exciting is circulating cell-free DNA. That is tumor DNA from the cancer itself that can be picked up in a blood test, has been shown to have a sensitivity and specificity in the mid-80s for early stage colorectal cancer in early studies. And also when combined with epigenetic and protein biomarkers, this cell-free DNA may actually have an increased sensitivity in the 90s, same with specificity. MicroRNAs may also be a tool to use for colorectal cancer. Looking at the microbiome may actually reflect the status of the host, and if you look at this picture on the bottom right, it can reflect lifestyle, environment, and also potentially neoplasia, and that's something that's being looked into. And finally, VOCs, or volatile organic compounds, which are released in the breath, may be able to be picked up by an electronic nose, something like what a dog can smell, because dogs can actually detect colorectal cancer in stool samples. And this may have a sensitivity in the 80 to low 90% and a specificity in the 60%. So a lot of exciting things on the horizon. The bottom line is there are a lot of exciting things to be looking forward to, and this slide summarizes what I've been discussing. Have a great meeting, and thanks for the opportunity to present this important material.
Dr. Sunanda Kane is a past ACG president and is professor of medicine at the Mayo Clinic in Rochester, Minnesota.
As we have heard, colon cancer is common and a leading cause of death from cancer. While it affects both sexes, there are data that in patients with IBD, women are at actually greater risk than men, and it is not really clear why this might be. If you have the liver disease called PSC, it is important to get annual colonoscopy to rule out dysplasia. Patients with PSC have a significantly higher risk for colon cancer than any other patient group with IBD. It is unclear why this is the case, but we know it to be true, and that patients with PSC should not get Cologuard, but actually get full colonoscopy with biopsies every year, starting in the year that they have the diagnosis of PSC. The cancer in IBD is faster developing than typical colon cancer, and the progression from low-grade dysplasia to high-grade dysplasia to cancer is measured in months rather than in years, like other polyp to cancer progression in the normal population. Patients with the highest risk are those with PSC, then ulcerative colitis involving the entire colon for greater than 8 years. We do know that active inflammation drives cancer risk because of cell turnover. So that means that control of inflammation and keeping patients out of flares is the way that we are going to optimize that variable in terms of developing cancer. Pseudopolyps can make it harder to see precancerous polyps. A pseudopolyp is a formation within the colon that looks like a polyp, but is actually just inflamed tissue growing off the wall. And that's why we call it a pseudopolyp. But you can imagine that if there are lots of pseudopolyps in an area, that a true precancerous polyp could get missed. Patients with ulcerative proctitis, meaning disease that's limited to just the rectum, are not at any increased risk for colon cancer, so they actually have the same risk as the background population. Patients with Crohn's disease are at an increased risk only if more than 1/3 of their colon is affected with the disease.
Dr. Asma Shaukat is a professor of medicine and population health and the director of GI outcomes research at NYU Grossman School of Medicine.
Colon cancer is common and it's lethal. It's the third most common cancer in both men and women and the second leading cause of cancer-related death in the US. Every American has about a 4.5% lifetime risk of developing colon cancer. The incidence of colon cancer in individuals 50 and older for both men and women has been on the decline over the past 20 years. However, for younger age groups between the ages of 20 to 49, we see that the rates of colon cancer have either been stable or in the last 5 or 10 years have shown an upward trend. So I'd like to talk about the American College of Gastroenterology clinical guidelines for colorectal cancer screening. And the most notable change is that colon cancer screening should now initiate starting at age 45. Similar guidelines were developed by the U.S. Preventive Services Task Force, and in their updated guidelines, the age to start colorectal cancer screening has also been dropped to 45. And this was given a grade B recommendation, meaning Medicare and all other payers will now cover this. There are many benefits of starting screening at earlier age. We can reduce this incidence of colon cancer in younger age group, and we can also boost screening in those 50 to 55. However, this needs to be weighed against the harms. Do we have enough access and resources? And also that we shouldn't worsen disparities. A quick word for individuals with a family history. There are now new guidelines that suggest that we should be starting them screening even earlier than age 45, starting at age 40. One first-degree relative younger than 60 with colon cancer, they should undergo colonoscopy starting at age 40, or one first-degree relative older than 60, then any screening modality is fine, but screening should start at age 40. And important that we obtain the records of any polyps, adenomas in first-degree relatives, and particularly pay attention to individuals younger than 50 in terms of earlier screening. Thank you so much.
Dr. David Kondas is a healthcare executive and patient of Dr. Ronald Hsu. He is a stage 4 colon cancer survivor.
In 2019, I was busy with all the usual aspects of my life, and I celebrated my 50th birthday. My family physician, my wife, and even my medical records app all reminded me it was time for my routine colonoscopy. The picture of me on the far left side of the screen was taken just a few weeks prior to my scheduled colonoscopy. I was feeling great. No sign of anything wrong, no bleeding, no symptoms, just normal everyday life. But that was about to change. The result of my colonoscopy led to a PET CT scan, an MRI of my liver, and a diagnosis of stage 4 colon cancer. If I had not gone in for my colonoscopy, I might not be here to speak with you today. At that point, instead of being a healthcare executive, I became a patient. The next step of my journey was a complicated surgery and 6 months of chemotherapy. I'm thrilled to say that the physicians, nurses, and other healthcare workers I encountered were exceptionally kind and caring. With the support of these excellent medical professionals, my family, and my friends at my side, I spent most of 2020 fighting this disease. I think it's important to state that while most of these pictures could give the impression that everything was okay, that is not how I always felt. There were many emotion-filled days, fearing the unknowns of treatment, depressed due to physical limitations, confused, sad, frustrated, and lonely as I tried to uphold a sense of strength for my family. In the face of these challenges, there was still hope. I could not have endured this without my faith, family, and friends there to give me strength. As of January 2022, it has been 2 years since my surgery, and I'm happy to say disease-free. I'm thankful for all I've learned through this experience, and I'm grateful for each day. I wish you well, and get screened. Thank you.
Dr. Neil Stollman is a member of the ACG Board of Trustees. He is the chief of the Division of Gastroenterology at Alta Bates Summit Medical Center. He is also the director of research at East Bay Center for Digestive Health and associate professor of clinical medicine at UCSF.
I wanted to really just relate a 1 or 2 minute anecdote and then let you go on your way today. This is a story I was thinking of today, actually, as I was talking to Ron about this program, and I think it just highlights how important this all is. I was in the hospital, it was probably a year ago. I was walking through the halls of our hospital in Oakland, and one of the nurses who I know quite well came up to me and told me her story. She was about 45 and no family history, no prior GI symptomatology, with some rectal bleeding. That she was straining and pushing, and she kind of came up to me in the hall and said, "Look, it's just my hemorrhoids, right?" And I said, "Probably it's just your hemorrhoids, but you're 45, and we should take a look." So we set her up, of course, to take a look with a colonoscopy. And while in fact her bleeding was in fact the hemorrhoids, there was also a large sigmoid colon cancer, and actually almost certainly incidental. I think her bleeding pattern in nature was in fact her hemorrhoids, but she in fact had at age 45 a sigmoid colon cancer, and pretty disruptive, of course, to her life. We took her to surgery fairly rapidly. We staged her, and she had a essentially likely curative resection. She has a T2 tumor. That means a fairly early stage tumor with no lymph nodes and no metastases. That's what the M0 means. So she is likely cured. And then sort of the interesting aftermath of this story. That's a story we hear all day, and hopefully that's a tremendous success story. But this is sort of almost a double success story, because normally when we find someone with colon cancer in their 70s or 60s, we actually say, hey, send me your kids when they turn a certain age. Colon cancer is familial, as we all know, and when we take care of a patient, we often talk about their first 3 relatives, their siblings or their children. In this case, it was a little different because she was young-ish, but she's got a dad in town, and her dad had never been screened for colon cancer. And I said, you got to get your dad in. That's not okay. And sure enough, dad comes in, and this is honest to goodness true. Dad has a cecal atop of his colon, asymptomatic, curable, also another T2 or T3, but a curable lesion in his colon, and he has now also had like I guess you say like father like daughter, in this case like daughter like father. Dad also had a curable colon cancer. And the joke, of course, when I see her still in the hallway, which I do all the time, is how much do we love those hemorrhoids, right? Those hemorrhoids brought her to step up and talk to me in the hallway. That brought her to a colonoscopy. That colonoscopy almost certainly saved her life. And without sounding full of hyperbole, it probably saved her dad's life as well. And that really just to me speaks loudly to the fact that of course colonoscopy works, of course colon cancer screening is important, and all of you here today are here because you already know that, so I certainly don't need to teach anyone that. It should be pretty self-evident to you, but I just wanted to share that little anecdote, and with that, my A, gratitude to Ron for putting this all together because it's pretty extraordinary, and B, my good wishes for you all to have a good day today, and C, just my enthusiastic support of this entire endeavor. Good luck to you all. Thanks very much.
Dr. Joseph Leung is Chief of Gastroenterology at the Veterans Administration Northern California Healthcare System and Emeritus Professor of Medicine at University of California Davis School of Medicine. Dr. Andrew Yen is Associate Chief of Gastroenterology and Chief of Endoscopy at the Sacramento VA Medical Center.
The VA serves over 9 million military veterans and is the largest integrated healthcare system in the United States, with over 1,200 healthcare facilities. In our region, VA Northern California Healthcare System serves an area consisting of more than 377,000 veterans dispersed over a wide geographic area spanning approximately 40,000 square miles, extending from the northern San Joaquin Valley to the Oregon border, and from the East Bay to the Nevada border. Over 100,000 veterans in our catchment area are enrolled in the VA healthcare program, and potentially over 60% of these veterans are eligible for colorectal cancer screening. Our health system provides access to colonoscopy at 3 locations: the main Mather campus in Rancho Cordova, Martinez in the East Bay, and Redding further north in the Shasta Cascade region. Within VA Northern California Healthcare, colonoscopy is the preferred and primary colorectal cancer screening modality. Colonoscopy can not only detect cancer, but it has the advantage of being the only screening modality that can also prevent cancer through the identification and removal of precancerous polyps. Nationwide, VA has a colorectal cancer screening rate of over 80% in the pre-pandemic era, which exceeds the National Colorectal Cancer Roundtable goal of 80% and is much higher than the national average. Nationally, the VA diagnoses over 3,000 cases of colorectal cancer per year, so there's still work to be done to reduce these numbers, and Dr. Leung will discuss some of our efforts.
When offering screening colonoscopy, we stratified our patients into average risk or high-risk subjects, that is, those with family history of colon cancer. We perform surveillance colonoscopy for those with a history of cancer and/or precancerous lesions. To accommodate a large number of patients awaiting screening, we created novel and innovative approaches, including the use of open or direct access colonoscopy, by which we triage all colonoscopy consults and schedule healthy average risk individuals directly for colonoscopy. We facilitate the process by conducting class education to provide patients with instructions and on-site dispensing on bowel prep medications, as well as scheduling appointments right after class. The COVID pandemic has affected the overall delivery of healthcare, and the VA is no exception. We prioritize individuals at increased risk for colon cancer or polyps for colonoscopy. We offer FIT testing as an alternative screening modality for younger and average risk individuals, and expedite a diagnostic colonoscopy if FIT is positive. Over the past 15 years, we have adopted a number of innovative approaches to optimize clinical outcome. At the Sacramento VA Medical Center, we pioneered the use of water exchange colonoscopy and reported the first randomized controlled trial comparing with traditional air colonoscopy. Our experience shows that water exchange colonoscopy improved bowel preparation quality, improved cecal intubation, that is a successful colonoscopy, in both sedated or minimally sedated patients. Water exchange also increased the overall and right-sided adenoma detection, which is of clinical importance because missed adenoma, especially in the right colon, is believed to be a cause of interval colon cancer. Water exchange colonoscopy also improved patient satisfaction by minimizing pain or discomfort during the examination. It helps to reduce or eliminate the need for sedation medications. We also offer the on-demand option that is patient-controlled sedation colonoscopy. Scheduled unsedated colonoscopy allows patients to present unaccompanied for their examination. We have other ongoing clinical studies to evaluate the benefits of water exchange, including the use of total water colonoscopy without air or gas. This represents a paradigm shift from conventional colonoscopy. A combination of dye and water colonoscopy further improved adenoma detection. Underwater polypectomy or removal of polyps is safe and effective, and we conducted the first U.S. clinical trial assessing this. We are also testing the role of tumor-specific peptides in the early detection of colon cancer. These are some of the studies conducted at our VA as part of the ongoing effort to end the burden of colorectal cancer.
Dr. Irving Pike is a past ACG president. He serves as Chief Medical Officer at John Muir Health in Walnut Creek, California.
The GI Quality Improvement Consortium Limited, or GIQuIC, was founded in July of 2010. It's a collaboration between the American College of Gastroenterology and the American Society for Gastrointestinal Endoscopy. This is a registry that tracks quality measures of colonoscopies for more than 4,700 gastroenterologists around the country. This is an electronic database that collates a massive amount of information and allows gastroenterologists to track their own performance and compare themselves to all others participating in the registry. This slide is a representation of how the registry works. If we direct our attention to the left side of the slide, these are gastroenterologists at various sites around the country performing colonoscopies, and at the end of the procedure, creating a report in an electronic report writer, which documents what was performed and what was found during the procedure. This is uploaded through the internet to a central data repository, where the information in the repository changes the reports of performance compared to those of others in real time, and this can be uploaded back into the internet and then received at the physician's site, giving that physician information about their performance as compared to all others in the registry, and this leads to improvement by everyone. The growth rate since July of 2010 has been tremendous, and we are now rapidly approaching 15 million colonoscopies in the registry, which is a treasure trove of information and research for improving the performance of colonoscopy and decreasing the incidence of colon cancer. One of the very important measures that is created within the registry is the adenoma detection rate for individual physicians. That is, the frequency with which an adenoma, a precancerous polyp, is detected on a screening colonoscopy of an average risk individual during a screening colonoscopy. Removal of this polyp removes the opportunity for that polyp to grow larger, degenerate, and form a colon cancer. The target performance for any physician performing colonoscopy should be an adenoma detection rate of at least 25%. What we have found in the GIQuIC registry is every year, since this first full year of operation in 2011, the mean value for adenoma detection rate of the participants has increased. In fact, it has increased significantly from 23 in 2011 to 41% in 2021. So what does that mean in relationship of colon cancer? This has been demonstrated by Douglas Corley with Kaiser, where he measured the adenoma detection rate of 189 colonoscopies within Kaiser, and then followed patients year after year, and found in the first 3 years the low but real incidence of colon cancer in those patients who had undergone screening for each physician was 60% lower for the physicians with the highest adenoma detection rate when compared to the lowest. And this remained true at least at 40% if followed for greater than 3 years. So the higher the adenoma detection rate, the lower the risk for an interval colon cancer. In fact, for every 1 percentage point increase in adenoma detection rate by a colonoscopist, there is a 3% decrease in the likelihood that that physician's patients will develop a colon cancer in the interval before the next indicated colonoscopy. Thus, an 18 percentage point increase in adenoma detection rate, as demonstrated in GIQuIC between 2011 and 2021, this decreases the likelihood of cancer by 54% for those doctors' patients. Thank you very much.
Dr. Paul Kuo is a member of the ACG Board of Trustees and serves as Professor of Medicine at Stanford University School of Medicine.
I would like to thank and congratulate the organizers for putting together this important symposium on colorectal cancer screening. With regard to colorectal cancer screening, quality matters, and in all healthcare screening endeavors, we are focusing on quality to ensure that our screening methods provide the highest outcomes and benefits to our patients who come to us for colorectal cancer screening, amongst other screening procedures. The adenoma detection rate is an important quality metric for colorectal cancer screening, and one that has been emphasized here at Stanford University. This seminal publication from Corelli and colleagues from the Kaiser Group showed an inverse relationship between adenoma detection rate and the risk of fatal colorectal cancer. The Stanford Colonoscopy Quality Assurance Program has been conducted under the direction of Dr. Yuri Lauterbaum, and the results are shown here. We show here various colonoscopy metrics for colorectal cancer screening, and you can see here, in addition to adenoma detection rate, we capture the preparation rates that are adequate, complete exam rates, and the minimum inspection time. And the results at Stanford exceed national benchmarks, which are also shown here in gray. We post these results, and the web link is shown here, so that those who are coming to Stanford or are interested in colorectal cancer screening can, in a transparent way, understand the results that we have generated. And again, it further underscores the commitment at Stanford and elsewhere to high-quality colonoscopy for purposes of colorectal cancer screening. Again, under the efforts of Dr. Lauterbaum, we've managed to extend our findings in our Stanford colonoscopy screening program and extend these beyond the adenoma detection rate. These results shown in this slide come from a paper recently published in Clinical Gastroenterology and Hepatology. You can see here that in addition to adenoma detection rates for a variety of other lesions, adenomas, sesosurated lesions, as well as combinations of all of these findings are shown here. In this important paper, Dr. Lauterbaum introduced the concept of the adenoma detection rate extended to screening and surveillance. And maybe moving forward, this will also potentially be an important metric to allow us to improve further our quality efforts to improve and reduce morbidity and mortality from colorectal cancer screening. Again, my thanks to the organizers for putting together this important symposium.
Dr. Daryl Gray is Chief Health Equity Officer at Anthem, Inc.
Colorectal cancer is the leading cause of gastrointestinal death and the second leading cause of cancer-related deaths amongst men and women in the United States. And this is quite tragic because we've had over 3 decades of evidence that colorectal cancer screening saves lives. Unfortunately, we continue to lose too many of our heroes and loved ones to the disease. On the left, you see Chadwick Boseman, noted actor who's played roles such as Black Panther, Thurgood Marshall, and Jackie Robinson. And we unfortunately lost him to colorectal cancer. And similarly, I lost a close friend who's pictured in the maroon jacket to colorectal cancer. And many of you may have stories of loved ones that you've lost to colorectal cancer. And the burden of disease is not equitably distributed. We know, particularly as we look at geography, as you can appreciate in the map of the United States on the left, those areas in red are considered geographic hotspots where the death rate from colorectal cancer is the highest in the nation. Similarly, we see inequities across racial and ethnic groups, understanding that the incidence rate amongst blacks is 20% higher than that among whites, and mortality rates are 40% higher among non-Hispanic blacks as compared to whites. And notably, non-Hispanic blacks tend to be diagnosed younger and at later stages of disease than other ethnic and racial groups. We certainly, as we look at screening uptake, we see similar inequities, not only by race as is present, but if we look based on other social drivers such as insurance. We see that those who are uninsured are least likely to get and complete colorectal cancer screening. Similarly, we see a dose-dependent relationship between income and screening. Those with the lowest income are least likely to complete colorectal cancer screening. Now, the barriers to screening are multifactorial, considering patient-level barriers, provider barriers, health system barriers, and yes, national barriers. But these are not things that are insurmountable. As a matter of fact, we also have evidence of ways and interventions that we can employ that actually allow us to overcome barriers at each of these levels: patient, provider, health system, and national level. As we prioritize how we improve the care and experience of underserved populations, those who are least likely to complete colorectal cancer screening, a life-saving measure, and more likely to die from colorectal cancer, there are 3 specific areas, and these are not comprehensive, but 3 specific areas that we should prioritize. One is actively promoting screening options, and the message that the best test is the one that gets done appropriately. Certainly, colonoscopy is a method that allows us to look throughout the entire colon and to remove any precancerous polyps if found, or to biopsy cancer if found, and hopefully it will be found early. But there are other methods, such as stool-based testing as one other example, that can be done in the convenience of one's home as a means of screening for colorectal cancer. Again, the best test is the one that gets done appropriately, so if that stool-based test is positive, the next logical and appropriate step would be to complete the colonoscopy to better understand why it was positive. Number 2, we need to develop and implement strategies to identify unscreened and uninsured individuals. This will allow us to target our interventions to those hard to reach or hard to engage populations who need this service, such as colorectal cancer screening. And lastly, develop and implement organized strategies for screening, such as mailed fecal immunochemical testing, to allow us to continue to elevate our colorectal cancer screening goal of reaching 80% in every community. You know, with all of this, we must be equity focused, ensuring that we tailor our interventions to the needs of each population. I like this illustration because it clearly distinguishes equality from equity. Equality says that we give everybody the same tool and hope that they achieve the optimal outcome. We know that won't happen unless we take an equity approach and provide people and communities with the tools that they need to reach the desired outcome, and that's preventing colorectal cancer. Get engaged if you haven't already. The ACG is the perfect place for those of you both in the community but in the professional or medical realm to get engaged, whether it's in research, in policy, in education, and outreach. Join us in this cause. I leave you with this. We can beat colorectal cancer together. I think of this story, What Would You Do with the Problem? And it tells the story of a young boy who one day faces his problem head on, and he says, my problem wasn't what I thought it was. I discovered it had something beautiful inside. My problem held an opportunity. We have a great opportunity. Let's leverage it together. Thank you.
Dr. Patrick Leung is the chair of the ACG Board of Governors. He is professor of medicine and director of the Digestive Disease Division at the Uniformed Services University School of Medicine in Bethesda, Maryland.
I really want to take a couple of minutes and talk about two things. First, the wins, and then the work. So the wins, we have finally, after 10 years of working toward it, saw the passage of the Removing Barriers to CRC Screening Act, which prevents the incurring of a copay when a polyp is found at screening. So this is a huge barrier removed. So many thanks to Representative Don Payne from New Jersey and others who helped with this initiative. And the second was removing the barrier when someone gets a positive non-invasive test, like a stool test for colon cancer screening, and needs to get a colonoscopy to follow that up and actually get some benefit and remove the polyp or detect the cancer that made the test positive. That was being charged for in many instances in the past. And now, as of January 10th, the Biden administration issued guidance requiring private insurers to cover colonoscopy when needed as a follow-up to these non-invasive tests. So these really are big deals that a lot of people helped to effect. And so thanks to all the hands who made this work seem like. Next, I want to talk about the work that's still left to be done. So during the pandemic, we discovered a few things about telehealth. One, many patients like it. Two, you can deliver for some conditions very effective care, particularly in pre-screening somebody for colon cancer related visits. And three, this helped decrease disparities. So people in rural areas, maybe without as good of an access to physicians, had improved health because of this. And so we're looking to have this continue to be paid for even after the pandemic is, thank goodness, long behind us. The second thing is helping legislators to craft language and policy around decreasing disparities. We know that for Black Americans, they're 20% more likely to get colon cancer and 40% more likely to die from it compared to other ethnicities. And the rate of colon cancer among the lowest socioeconomic status is 40% more than in the highest. And so this seems like an injustice to us, and we would love to see good policy, good social outreach programs that would help in this way. And the last thing, which actually just came to fruition, believe it or not, is coverage for screening at age 45, which is a new recommendation from the American College of Gastroenterology and others. So thank you all for having me, and I look forward to answering your questions.
Dr. Dana Early is Vice Chair of the ACG Board of Governors. She is Professor of Medicine at Washington University School of Medicine.
So the key question really is routine surveillance colonoscopy. So when you've previously removed an adenoma and you're doing the follow-up, is that a diagnostic procedure or is it part of the screening and preventive process? Well, we at the ACG, and I'm sure you, say it is part of the screening and preventive process. But how about insurers and CMS? And what does the United States Preventative Services Task Force say? Well, as it turns out, the USPSTF is really silent on this issue, and that has made it somewhat difficult to advance this issue. So as you know, there are really two ways to approach colon cancer screening, and one is one-step screening where you perform an initial colonoscopy and remove polyps. Unfortunately, Congress waived cost sharing when polyps were found in 2022 with the Removing Barriers to Colorectal Cancer Screening Act. Also, the issue of two-step screening when a non-invasive screening test is positive and a colonoscopy is warranted. This coverage has also been addressed recently with legislation so that there's cost sharing waived for these. However, we need a policy to waive cost sharing for follow-up colonoscopy when adenomas are found. So the ACG took action. We're still working on this issue. We did engage an insurance company that we knew was considering surveillance colonoscopy as diagnostic. We have also engaged the AHRQ and CMS. And what we've tried to do is highlight the importance of colon cancer screening, important it is to consider a surveillance colonoscopy part of the preventive and screening continuum and process. And so we remain committed to this effort, and we'll update you as new developments occur. Thank you.
Dr. Daniel Anderson is president of the California Colon Cancer Coalition and voluntary clinical professor at the University of California, San Diego School of Medicine.
The first thing we had to do is make sure the U.S. Preventive Services guidelines stated that colonoscopy after a positive stool test was part of the screening process. And this is because in 2016 we had passed a law to remove the cost sharing, but Governor Brown vetoed it because it exceeded the U.S. Preventive Services Task Force description of the colonoscopy after a positive stool test, because they said it was a follow-up colonoscopy that could be interpreted as a diagnostic colonoscopy. We got a team of experts together to recommend the necessary changes in the guidelines when they were released in 2021. The U.S. Preventive Services Task Force response was perfect. They said that screening could include a combination of screening tests, such as a fecal test and a screening colonoscopy, and that the positive results on stool-based screening tests required a follow-up with colonoscopy. As a result of these changes, we were able to pass a bill in California to remove cost sharing after a fecal test. And more importantly, on January 10, 2022, the departments released regulations that removed cost sharing from the colonoscopy after a positive non-colonoscopic test in all commercially insured people in the country. Our other major effort was to add colorectal cancer screening to the California Medi-Cal Managed Care Accountability Set. And since 2019, California has been using the CMS Medicaid Adult Core Quality Measure set, and colorectal cancer screening was not part of that set. This is important because Medi-Cal screening rates are really unknown, 19% when last measured in 2021. If you have Medi-Cal insurance, your late-stage diagnosis of colon cancer is the same as California's uninsured population. We had to work with Mathematica that contract with CMS to make changes in the core measures. And in the fall of 2020, we had to get one of their voting members to recommend colorectal cancer screening for addition. We were able to do that with the people listing on this slide. We helped them with the completion of the nomination form, and it was accepted to be considered in May for addition. In May, it was discussed, and after discussion, support was given by the people on this slide, and it passed and was recommended for addition by unanimous vote. We were able to complete the steps on this slide, and it was added in December of 2021 and will be measured in California in 2022.
Dr. George Triadafilapolous is clinical professor at Stanford University School of Medicine.
On the opposite side of my photo, on the top left of the slide, you see an image of a colon cancer, the topic of the day. This picture was taken at colonoscopy. The reason we're here today is to figure out ways to erase the word cancer, specifically of the colon. You have already heard our panelists discussing what all of us are doing to beat genetics, lifestyle, disparities in healthcare delivery, and even bad luck. Today, we're going to do all this together with music. For centuries, music and medicine have been linked. Musicians, composers, and performers, as well as physicians and surgeons, use their brains and their hands to bring relief of emotional and physical pain and to prolong and save lives. Music can start the communication between physicians, nurses, patients, and families by bringing them together. Played in the background, music drives conversations, helps us find common ground, and can even synchronize our understandings and attitudes. But most importantly, music, any music, restores our energy and helps us maintain a positive perspective on life and on our health. So today, thanks to the American College of Gastroenterology, our governor, Dr. Ronald Hsu, the panelists, the musicians, and with all of you participating, we're here for a big treat, to fight colon cancer with music and conversation. Baroque music was a tool of expression and communication in Western Europe for more than 150 years, and is still favored by many of us today. It is calming and relaxing, while at the same time it's inspiring, melodic, and exciting. Personally, I cannot imagine a better Sunday morning than that of sipping my coffee and reading the news in the company of Baroque music playing in the background. The portraits that you see on this slide are those of the Italians Arcangelo Corelli, Antonio Vivaldi, and Francesco Geminiani, of the Englishman Henry Purcell, and of the German Johann Pachelbel. They wrote the pieces that you will hear later on today by a group of musicians, the first and second violins, the viols, the cellos, the bass, all of them around the harpsichord. The Frenchman, Marin Marais, among them on this slide, was a master of the viola da gamba. He is one who composed a piece called Le Tableau de l'Opération de la Taille, which will also be presented with its French lyrics. Thankfully, medicine and surgery, not to mention anesthesia, have dramatically improved since. On the left of this slide, the colon polyp is seen on a video screen during a painless colonoscopy performed by a gastroenterologist. These polyps are safely removed in more than 99% of cases. If the polyp is missed or not removed, it may turn into cancer, a photo of which you see on the bottom left on the slide. When colon cancer is found, it can also be removed through small incisions and sophisticated instruments using video imaging, as shown on the right. For some of us, listening to Baroque music in the background while performing colonoscopy or surgery is a way of soothing our nerves and helping our concentration. Some surgeons, of course, may favor heavy metal music or classic rock over Baroque, but the anesthesiologists typically object. This meeting is about information on a nasty killer, colon cancer. It is about understanding why, how, and when it happens, what it does to human lives, young and old, to its victims and their families. Our panelists share their thoughts and practices with you. You participated in this gathering, you understood and learned a lot. But this meeting should be a call to action on what we can do to prevent the problem, deal with it, and make it vanish from our lives. It is a meeting about hope, about life without colon cancer.
Thank you for your engagement during the first half of the seminar, and thank you to each of our speakers who have shared the expertise in the importance of colon cancer prevention.
Speakers come up here. We're going to join by live now, live from East Coast and everywhere. Some of our virtual speakers will be joining us Zoom. And can I invite the speakers come up here? And Angel, come to join us. Where's Michael? Yeah, come join. Oh, okay. Well, I have to thank all the speakers. They really have shared with us all this very important information. I know it's a little high-powered for some, but it is important because I think once we hear about it, it may not matter today, but it may matter to you later. Even our younger generation, if they hear it now, when they come to their time, they will understand, it will resonate. So we are now joined by our ACG president. Can you hear me? Great.
I can. Hello to everyone, and I'll add my thanks and welcome. This is so exciting. I can't wait to hear the music and see more of the program.
Thank you. Wow. You know, these are all the big shots from ACG. You know, they're all our presidents. And actually today we have all the big shots joining us in virtual and in real person. Good. So, Mark, are you in New York? I see your background.
I am. I would say good afternoon to everybody from New York. It's nighttime here.
Thank you. Thank you very much. And so on stage we have Dr. Leung here, we have Dr. Pike here, and Dr. Yan, and Paul from Stanford. And I have my patient who is actually here too. I'm so grateful, it's so nice to share his experience with us. And it's so important, any life story really hits us. In fact, I have many friends, personal friends, neighbors. One day I see them, a week later they got sick, and then a year later they're no longer with us. So colon cancer is very common, and the age is getting younger. So everybody should really think carefully and make sure we follow the guidelines and do what we need to do. So, okay, now we have two other important persons here. Can you see them? So we're just joined by Angelo Moreno. Can you see on the screen? And then Michael Sand is here. Now I have to thank both of them because they are the two musical directors, put everything together. And it is, you will see it soon. It's amazing. Thank you, Michael, and thank you, Angelo. Yeah. So, Dr. Leung? Dr. Leung is actually important. We all started it because we talked about it last year, and then he really encouraged me, and then we put together this program. He really has the backbone for this program. Dr. Leung, you want to say something? Well, I can pass it to you.
Ron, congratulations for putting together this wonderful meeting. We look forward to the music part. And I also appreciate the support of the ACG officers that have lent a really helping hand in involving the college office in helping us to put together this program. But again, Ron, congratulations.
Thank you. Dr. Pike?
Thank you, Ron. It's a real honor to be a part of this program. It's not easy to put together something of this magnitude. Mark, who you see on the screen for those of you here today, has been tweeting about the program. I've been sending some photos to him, and Mark is very facile with social media. And has been a wonderful leader for the ACG. Mark, as you know, has formed a very close relationship with GIQuIC, who may have made the biggest difference in decreasing colon cancer in the country. It's really very nice to be here, and I'm fortunate to be close enough to get here. Thank you.
Paul, Paul is from Stanford University. He drove all this way and got in the traffic for a long time, right? I-80 is not a very nice drive on Saturdays.
No, but we really appreciate everybody's efforts, Ron, to come out, and congratulations to you and to the college for putting on such a wonderful program. It's just great to see that we've assembled the tools to really make a significant impact in reducing colorectal cancer screening or colorectal cancer mortality, and importantly, we can offer screening on a wide variety of measures now to reduce morbidity and mortality. And looking forward to the rest of the program, particularly the music, Ron. I was going to select my next music to try and improve my ADR, just based on whether it's Baroque or other.
Yes, thank you. How about Paul? Patrick, are you there? Patrick's our chair of...
I am, yeah. Thank you very much for having me. This is obviously a wonderful event, a very near and dear subject to a lot of our hearts. I think clinically this makes up a lot of what we do, is trying to prevent colon cancer. I think if I were there, I would be like 10th or 11th chair, probably, as a musician. But I really enjoy music, both performing and listening. And so I'm very excited. And thank you, Ron, so much for putting all of this together.
Dana, hi.
Hi, everybody. It's great to be a part of this group. I think this is just a wonderful program, and I was very excited to be asked to contribute and participate, and just thank you so much.
Thank you for joining us. And we have also Daniel from San Diego. Dan, Stoney Anderson. Can you hear me?
Yes, it was a great program. I really appreciate it. So thank you so much for inviting me. And the behavioral risk factor surveillance system was weird because, we were ahead of the United States in 2018. We were at 72% and we dropped to 62%. And the US during the pandemic went from 70% to 74%. So I think some of our figures from the pandemic are off. So anyway, we do need to do better, obviously, but the pandemic really hit us in California. It hurt our federally qualified health centers. But with the Medicare being measured, it'll help them because about a third of Californians are insured by Medi-Cal, which is our Medicaid system.
Yeah, the pandemic hits everything. You can see everything is like decrease and attendance is not good because everybody is virtually present. And in fact, when I spent these last 2 years, I have been virtually everywhere in my own room, but I see everything else in somebody else's room. So virtual platform has really opened up a lot. And in fact, we have plenty of people watching us at this moment, and they are virtually present. And so I would like to introduce David here. David, David is amazing. I met David how many years ago? 3 years ago.
Yeah, 2 years ago. Yeah.
Davis came to me just a week before Thanksgiving. And so he came in and did the colonoscopy, and I had this news to tell him just before Thanksgiving. It was so hard. But I'm so grateful that you come in to share your experience. And I think this is so important. Your life's experience really tells a lot. And there are many other people around that need to hear about it. And hopefully we can prevent this deadly disease way before it happens. Thank you, David, for coming. And thank you. Your wife is also here too, right? Yeah. Thank you. Hi, thank you very much.
Thank you.
Okay. Ed.
Oh, yeah. Thank you. So congratulations, Ron, and the ACG for putting on this course. Thank you for having me involved, and thank you to all the speakers for coming. And thanks to all the participants here in the crowd, for spending your Saturday with us. We know you could be doing other things, but hopefully this program so far has been worthwhile, and we all look forward to the music program.
Yeah, thank you. Okay, can I have Angelo and Michael just... Because, we are sitting at the back, nobody can see us. Where is it? I'm looking at the screen. Where is the screen? Hey, now, Angelo is really a good friend. Yes. And he's also the teacher. And Michael, come here. So now, both Angelo and Michael are my teachers, and they have taught me a lot. And I'm so grateful that they put out this music program for us. And the students is amazing, so I hope you will all enjoy this. And at the end of this, the most important thing is to get the message through. When we talk about colon cancer, we want the message to get through. But today, we also have some nice music, which is Baroque music. How many years ago? 300 to 400 years ago. Why do we want to listen to it? You will find out.
Well, first of all, thank you, Ron, for inviting my students and I to be a part of this, and for connecting my students with Michael Sand, who is my mentor, who taught me everything I know about Baroque music and inspired me to create the first Baroque ensemble at the high school level in the country. There had never been a Baroque ensemble. I had no idea that was the case until I created one and was told that. But Davis High was the first group to model it after Michael Sand's ensemble at UC Davis, which I grew up studying music there with Michael. And I came across Ron and became good friends with him and his family and taught both of his kids and Ron. And Ron and I took a wonderful tour to Italy and experienced so many great life experiences playing music together in so many beautiful cities and cathedrals. And since then, Ron has been a member of the UCD Baroque Ensemble, and we both learned so much under Michael's direction. And so this entire week, my students and I have been working together with Michael, and Ron has joined us, and we've had rehearsals every night to prepare our show for you. And I have to tell you, from a student level, and I think as far as every adult in the room can agree, music has the ability to bring people together socially, give us many, many life experiences that we wouldn't have otherwise. But it's also the connection to medicine. It's the great healer of our mind and our spirit. And especially after the last 2 years of what we've experienced with this pandemic, I literally taught 5 orchestras over a computer, if you can imagine that. And never got to hear the harmony of my students. We had to be over Zoom. and we couldn't actually play together in real time. And this year we've turned that around and had such a wonderful time together, and we look forward to sharing that with you today.
Thank you. The last time I played before an audience, the last time I played other than in a room by myself was 2 years ago come March. And I think it was the middle of March that we had a Baroque ensemble rehearsal over there at UC Davis. And nobody knew that that was when the curtain was going to come down. And now 2 years, almost completely 2 years later, the curtain is coming back up. And I'm really very happy that that's the case.
Yes, good.
Thank you for being here, Michael.
Good. Dr. Shah, anything else you want to help us? And can you?
No, I can hear you. I just wanted to say thank you to you and the organizers, to the musical directors, Angelo Moreno and Michael Sands, and especially to the Davis Senior High School Baroque Ensemble, who I know have been practicing very hard. So looking forward to listening. And like Patrick mentioned, I tend to listen to 80s rock music when I scope, but I'm going to try Baroque and see if my ADR changes. So.
Now, that's the most important person who summarizes our program. George is from Stanford, and he is right there. George, can you hear us?
Can you hear me?
Yes, we can hear you.
Hi, everybody. Thanks for inviting me, Ron, and thanks, everybody, for participating in this important symposium for educating our public and our families and friends. And I appreciate the invitation. Thank you very much.
Yeah, George, thank you very much for your summary of this program. I think you like Baroque music. Okay, thank you. Now, we are going to take 10 minutes break. We're going to set up, and we will come back at 2:30 sharp. Thank you. Thank you for coming back. So our program is the second half now. If you look at the title, it's Bridging Medicine and Music. First, when you look at us holding the instrument, the string instruments, every one of us has a bridge on it. And if you look carefully on the title, there are some subtle words, medicine and music. But when you look carefully, deeply, you see me and us. So when we play music, we play it, but it's for us, and it's all for us. This is the signature of our program today. Today I'm holding this instrument. Definitely you know that I cannot do a colonoscopy with this. It's very different. And this is a 300 years old instrument. Nobody wants to use it. But in medicine, we always like to have the most advanced and the newest technology and the newest instrument. But when it comes to Baroque music, we want the oldest and the most original. And when we play Baroque music, it's very different. You know, there are all types of music, but when we do Baroque music, it is going back many, many years ago. And those was written long time ago, and it still resonates in these days. But when we do medicine, we always look for the newest, and we keep advancing. There's a big difference. So there's, when we look at musical note, Eric, just a single note like this can mean many, many different things. And for us, it can be just an ornament. It can be just a signature. But when this note is put on the music paper and the score, it will come out very differently. All the musicians will start to express their emotions and also their feelings, and will come up with very nice tunes and melodies. I have looked at this, and I play music many years until I meet Angelo and Michael. I played the music as this is written, and I never understood why I can never sound like them. And even now, of course, I don't sound like them, but I think I got a little closer, maybe 10%. Now today, I'm so honored to be here, and I'm very humbled. I have to thank the Baroque Ensemble. For me, I am not a musician, I'm just here, and I think the most important thing is to convey a message. When we play music, we want to convey the nice music so that it will get into your brain, and then later on you listen to it again, it will resonate. So this morning we have the seminar. I hope you got the message that if we want to prevent colon cancer, we have to do something to do that. And then now when we listen to the music, even if you never heard it before, you heard it for the first time, down the road, you will resonate again. So I'd like to introduce Michael and Angelo. We're going to start the program? Yes. Thanks. Can you hear me? Yeah. So if you look at the program, it's 4 pieces, and this is a French piece, which I would not want to speak the language because I don't speak that. But anyway, when a doctor finishes an operation, we write very detailed operation note. Now let's listen to how a French Baroque musician will write the operation note to us.
L'opération, le tableau de l'opération de la taille, l'aspect de l'appareil, résolution orientée, frémissement et la voyante. Descente de dit appareil. Fraction sérieuse. Entrelacement les soies entre les bases et les jambes. Ici se fait l'incision. Ici se fait l'introduction de la fenêtre. Ici sur l'arrière. Ici l'on perd quasi les voix. Écoulement de sort. Les relevailles.
you another example of musicians' humor. This is a piece by Georg Philipp Telemann, who is a contemporary of Bach and Handel. And he wrote a suite for a duet for 2 violins that's called the Gulliver Suite. And it's based on Gulliver's Travels, which was published in, I think, 1724. Before 3 years had passed, it was an international bestseller, been translated into European languages, and Telemann wrote this suite, knowing that everybody had read the book. And so the first movement of this is this little introduction to Gulliver himself was a surgeon and ship's captain. And in the course of many voyages, he came upon a lot of mythical islands. And the first island that he came upon was Lilliput, which is where the people were 6 inches tall. And the piece that Telemann composed, the Shaukat, for the Lilliputians, since they were tiny people, he wrote it in the tiniest musical division that you could possibly have. Usually a Shaukat, like we just played you a Shaukat actually in Purcell, is in 3/4. This one's is 3/64. So, and because they're such tiny people, they talk in slightly shrill voices. The next voyage he went to the island of Brobdingnag, where all the people were 60 feet tall, and he wrote a jig for them. Jigs usually are in 12/8 or something like that, and this one is in how many? A huge number of big open notes to show that they were big, huge people dancing. So there are 2 more moves after this, but let's play these 3 for you, and then we'll tell you about the thing that comes next. The last two islands that Gulliver went to, the first one was called Laputa. And in Laputa, it was populated by a race of extremely intelligent philosophical people who walked around all the time investigating the heavens and very often tripped over their feet as a result because they weren't watching where they were going. So that's what we're about to show you. The last island that Gulliver went to, he found two races populating it. One was extremely civilized race that resembled horses. They were called the Winnetums. There was also a race that resembled human beings, and these were extremely uncivilized. They were the Yahoos. And Telemann, in order to show the contrast, he writes the most elegant of dances for the Winnetums, which is a French dance called the Lure. I'm going to play through just so you can hear it by itself, and then we're going to take turns playing who is the Winnetum and who is the Yahoo. I'm going to switch, which will show you how easy it is to go from being civilized to uncivilized. So here to start with is the highly civilized French dance called the Lure. Choice playing a concert for doctors to choose a piece called Hypochondria. And I knew about the piece, but I didn't know why it was named that. A little bit of research, I still don't know why it's called that. Nobody seems to know. It's just a name that got stuck onto it.
special guest tonight. And I would like to introduce the very special guest to come. Yeah? The guest is coming. Okay. Okay, I think you like this Baroque ensemble very much. I do. And
I just wanted to say thank you to Ron for having us and for setting this great Baroque workshop up for my students with Michael Sand. And we appreciate Michael coming down from Oregon to join us for the week and working so hard. And everybody got an envelope today and a little Baroque tour flyer. And I just wanted to announce to you, you're one of our first audiences that I've made this announcement to. 2 years ago, this group was headed off to do a European tour, and then we had all the schools shut down right when we were in the steamrolling towards our goal line, towards fundraising. The travel ban happened, and I had to walk in front of this orchestra and tell them that our tour that we had been planning for 2 years had come to an end. I'm very excited to announce that next June, we're going to be headed back to Europe to showcase this wonderful orchestra and some of the most beautiful cathedrals in Europe. And we would ask you to, if you enjoyed today's performance, come back and see them again all of next year and be one of the great friends of this orchestra. Come enjoy their performances. And if you would, please contribute to their tour fund, because we are in the process of raising $60,000 so that every single student can attend this tour June of 2023. So thank you so much for all your support and for coming out today.